for the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, the Parthenon, and moments on the river line.
Just the last name of the day.
How lovely it was.
My first name in it too. Okay, name your first.
Many's the time that we feasted, and many's the time that we fasted.
Okay, Barbara, cut it.
Well, it was swell while it
Our
lasted.
last speaker will be giving two presentations today. We have a special guest. We have Thomas Weiss.
Okay, we're going to finish early. This is my commitment to you. So we have to start off with the story. So you heard about the lovely elderly couple that went to see their primary care doctor for their annual exams. And the gentleman goes in first, and the doctor does a head-to-toe physical, and this fellow is fit as a fiddle. And he says, Bill, your physical exam is like it always is. You're in great health. Your blood work's back. Everything is hunky-dory. You're doing well. Do you have any health concerns? And the gentleman says, well, I have one. He said, the first time that I make love with my wife, afterwards I'm very cold and I'm shivering. And then the second time when I make love with my wife, I'm very hot and sweaty. Well, what could that be, doctor? And the physician he's just utterly baffled. He says, I'm not sure. Let me think about this. I'm going to see your wife and examine her, and maybe I'll get a clue. So he brings the gentleman's wife in, and he examines her, and she's in equally great shape, really good health physically, normal physical exam, normal blood work, and he tells her that she's doing fine. He says, but perhaps you might help me. Your husband had an unusual complaint, and I'm a little baffled. He says that, the first time that you have relations, he's extremely cold and frigid and shivering. And the second time you have relations, he's hot and sweaty. Do you have any idea what that might be? And the man's wife says, oh, she laughs. She goes, that old coot. The first time we have sex is in January, and the second time is in August. So the purpose of that tale is that you gotta get a history. You gotta get a history. So this is again a little presentation that Morningside Ministry asked me to develop, and I guess it has a history to it, and I remember when I was a psychiatrist in the early 1990s at Wilford Hall Medical Center, and in would come a wonderful family with the patriarch, and they'd say, something's wrong with Grandpa, with Dad, and we would examine the gentleman, and now remember this is a historical piece. This is the early 1990s, and I would make a diagnosis of organic brain syndrome. This is DSM-3 years, okay? And at the time, we had no medicines, no treatment, but we would treat these folks with hydrogene, which is a European drug that's a purported cerebral vasodilator. And the idea would be that we'd increase blood flow to the cerebral cortex, and it would be helpful. And it did nothing, but it was better than just shaking the patient's hand and telling the family there's nothing we could do back then. We just didn't know. You don't know what you don't know. And that was just the early 1990s. So here we are 25 years later, and we know a lot about dementia. And I'm just going to talk about the four most common. And, we've had this reorganization in our diagnostic Bible. We don't even call them dementias anymore. They're either minor or major neurocognitive disorders. And you can put some money down that as time passes, will further differentiate and fractionate and stratify the dementias, okay? Because the good news is, while we might not have better treatments and we don't have the vaccine or vaccines yet, we've got a lot more knowledge and a lot more information. Some of it's derived from advances, enormous advances in neuroimaging. Some of it comes from animal models. Some of it comes from just really careful study of circuitry and regional blood flows. So this is already probably dated, but we'll talk about 4 common dementia syndromes, when in the 1990s it was just one big lump called organic brain syndrome, whatever that might be. And then the last piece is a geriatric psychiatrist, I'm going to guesstimate that probably not a week goes by where someone, maybe a family member or a patient, will say, so Dr. Weiss, I'm really glad that my mom doesn't have Alzheimer's disease. She just has a dementia. Or a patient will say, so my primary care doctor said I have Alzheimer's disease. You know, what's that mean? And my quick answer is, and you already know this, so dementia is an umbrella term for a progressive neurodegenerative disorder. Just like pneumonia is an umbrella term for, you know, an infection of our lungs. But like pneumonia is a broad spectrum term. You know, we have different types of pneumonia. We've got viral pneumonia, bacterial pneumonia, fungal pneumonia. And each one of those types has a different origin, a different cause, a different course, a different treatment. And by the same token, that's true with dementia. Dementia is the umbrella term, but we kind of stratify them into 4 common dementia syndromes. And this is going to be lightning quick. I'm going to use case vignettes. I'll do comparisons at all points in time. But at the end, I'm going to sum this up in one sentence. It won't be a very big sentence, but at least it's a take-home sentence. And I'm not going to talk about treatment, because that's a whole different ballgame. So we're just going to talk about differentiating the 4 common dementia syndromes. Okay. So before I begin, what are they? Well, I already said Alzheimer's. Throw another one out. Vascular. Beautiful. Numero 3. I can't hear you. Lewy body, dementia Lewy body. Yes. Frontotemporal dementia. Beautiful. Brilliant. So those are the 4 we're going to talk about. So we think today that these 4 syndromes maybe account for 90% of all cases of dementia after you clear out the, quote, reversible, end quote, causes of cognitive impairment. And these are the ones we look for all the time because they're quick fixes. You know, is there a metabolic imbalance? Is this a thyroid disease and it's mimicking dementia? Is this a vitamin deficiency disease? Is this a bacterial infection like tertiary neurosyphilis? Okay? Is this a pressure-related disease like normal pressure hydrocephalus? Okay. So those are all quickly diagnosed, quickly treated, if you will, mostly reversible, sometimes not completely, but you know, the things we all love, you know, the quick fixes. But these 4 are not quick fixes, far, far from it. So use abbreviations, AD for Alzheimer's disease, VAD for vascular, DLB for Lewy body, and FTD for frontotemporal. And I first gave this presentation to a group of hospice physicians, so I will beg your grace, there's a ton of abbreviations. I'll try and translate them quickly, but it's just, I didn't really think about that. So, here's our little vignettes, and they're very microscopic. So here's a, but I'll embellish them a little bit. So here's a 70-year-old man in great shape. And by great shape, he's got a wonderfully healthy heart and lungs, and he doesn't have diabetes. But he does have a history of progressive, underline that word, memory loss, mostly, primarily in the short-term domain. He can remember the first kiss, first date, high school reunion, but he can't remember what he had for breakfast this morning. His daughter is now having to step in and remind him of appointments and remind him to take a bath, do the wash, clean the dishes. He used to be a wonderful driver, knew all the back roads and shortcuts in his city where he lived all his life, but now he's getting lost and confused. And money problems, not able to keep his bills straight. His physical exam is perfect. And we'll just use the simple, outdated to some people, copyrighted to others, mini mental status exam. It's been out since 1975. And it was intended originally for delirium, not for dementia, but we'll just use it. And you know, today he scores 20 out of 30, which we put him in the quote, mildly impaired range, just on that indices, okay? So what do we know about Alzheimer's disease? Well, we know a ton. I always like to make the pitch. We know it's still incredibly underfunded for such a, you know, a growing disease and an incredible burden. I mean, the funding is microscopic compared to other illnesses like HIV disease. But we think it may be the most common dementia in adults over 65. Now lock onto that number, okay? Because we're going to use some statistics here that will guide us. You know, we used to play this game in psychiatry residency where we just give a sex, and then we had to kind of say, is that more depression or bipolar, and then an age, and you know, we build this case just based on epidemiologic stuff. Obviously, we didn't have much to do in our day. You know, we went to medical school at Hippocrates and didn't have a big fund of knowledge. So, most common dementia in adults over 65. We know now that there's a ton of pathologic mechanisms. I mean, Alzheimer in 1906 drew beautiful pen and ink depictions of the senile plaques which are outside the neuron and the neurofibrillary tangles that are inside the neuron. Those are kind of the hallmark. These are abnormal depositions of protein that kill the neuron and reduce cellular signal. But we know there's other pathways of destruction, you know, oxidative damage, glial dysfunction, mitochondrial dysfunction, inflammation, the list goes on. So this is a disease that has lots of different vectors, but we're pretty obsessed right now with senile plaques and neurofibrillary tangles being kind of the heart of the disease. And we know that, you know, once you make the diagnosis, it's got a long course. This isn't a short, virulent one. This is a long road of suffering for the patient, and as I often say, it's a 2-for-1 Kmart blue light special. The patient and their caretaker both suffer abundantly because the person is dead while they're alive in many ways. It's kind of a living death. Memory decline is the hallmark. There's that insidious but relentless progression. And, you know, that's the sine qua non of diagnosis. You either have impairment in language, you know, aphasia, or in recognition. You know, aren't you offended when you sit in an airplane seat and they tell you how to buckle the seat belt? You say that's utterly simplistic, but to someone with moderate to severe Alzheimer's disease, that's Herculean. Okay? Recognizing and being able to do the movement, praxis. But really the biggest catch-all area is the fourth one, disturbances in executive function. all the things you and I did today, completely on automatic pilot, from when we opened our eyes, got out of bed, showered, groomed, dressed, made breakfast, got in the car, drove here, went to work. The billions and billions of decisions and actions that you made automatically and unconsciously all demonstrate executive function. Because maybe you're driving down Fredericksburg Road, where my office is, and they said detour. And someone with Alzheimer's disease cannot make that executive function, that change, that adaptability. And motor signs. What you're going to see in Alzheimer's disease is not a lot, if any, motor signs. So what are motor signs? Disturbances in gait, tremor, okay? Usually you see those later in the disease. And behavioral changes, you don't see those changes early, but they're common in the mid and really in the late stages, changes in behavior, you know. And this has a broad spectrum. So delusions, hallucinations, apathy, depression, inappropriate behavior, problems with eating, problems with sleeping. So there's, you already know this. This is just the, but we're going to use Alzheimer's as sort of the template to compare the other three. So there we go. So vascular dementia. So here's a 65-year-old guy. So right away you say, well, he's in that age group. You know, he has a 5% chance of having Alzheimer's dementia, but he's not healthy. He's had high blood pressure a long time and diabetes. We didn't say whether it's type 2 or type 1. And then the other day I discovered there's a type 3. I really feel out of it as a psychiatrist. Yeah, type 3 diabetes. I know, you're all looking the same. Yeah, type 3, so do your homework tonight. And CID is coronary artery disease. So this gentleman has got his share of troubles. And lo and behold, it looks like he had a stroke 6 months ago. So he's weak on his left side, arm and leg. Speech is slurry and hard to comprehend. But it resolves. It resolves. But his bride, his partner, notices that he can't name his grandchildren. And he doesn't take medicine, so he's struggling. She's got to help him out. Nor can he operate a remote control. Always a key sign in the male species. Key sign. And he was sort of a wannabe cook. Can't cook anymore, because what does cooking take? Executive function, decision-making, sequencing, sometimes abstracting. I don't have that spice, so I'll try this. Okay. And what do we notice on exam? There's a pronator drift. And you don't need to take a reflex hammer, you just go bing, he's hyperreflexive. So, vascular dementia, right away, from the history, just from the history alone, this gentleman suffered an insult to the command post. He's had a stroke. And there's been damage sustained. It's kind of like a ship, you know, you seal off the watertight compartments. But you know, one of the engines is knocked out. You've taken on water. Wow, I'm starting to slip into my Navy Reserve personality. This is dreadful. So, we know a lot about vascular dementia. There's all types of it. Multi-infarct, single infarct, lacunae, these are little islands, okay? Genetic forms, hypoxic encephalopathy. But you know what? These all boil down to problems with blood flow and plumbing, okay? There's either been a leak or a valve's been shut off, and both of them are disastrous. So lots of pathology, lots of anatomic destruction, if you will, but it's hard to see, although now we have imaging that lets us finally see this to a degree. And these folks have, when you see focal deficits, that means on their neurological exam, they're not intact like our Alzheimer's gentleman was. And here's the kicker. Very early on, notice in his history, executive functioning. This isn't so much memory, but it's, you know, how to do things, although he forgets the names of his grandchildren. But can't can't function, can't make decisions. Early on, 3 months later, wham. So there's kind of he's taken a step off. This isn't a slow, insidious progression. This is stepping off and then plateauing out. So let's compare and contrast. So on your far left is sort of these are just highlights, just little highlights. Just if you take home one of them, that's a great thing. So we've got vascular dementia in the middle, and we're going to compare and contrast it to Alzheimer's dementia. So typically speaking, these folks are already at risk. So that client you're working with that's got high blood pressure, got diabetes, got coronary artery disease, they're more at risk for vascular dementia than somebody that doesn't have them. And this poor soul has all three. The onset, what do we notice here? This is more sudden. Can be gradual, but it's generally sudden. There's a step up. There's that progression. They've got neurologic deficits. Over on the right, WNL is just medical speak. I know you know this for within normal limits. Their gait, usually you see gait disturbances. They have trouble walking. Maybe he's got a residual hemiparesis, so that left side is weaker, so maybe he has a very mild limp. Memory, mild impairment, early on. With Alzheimer's disease, it's much more prominent early on. Executive function, terrible early on in Mark. Executive function starts to fade in the middle stages of Alzheimer's dementia. So the Hitchinski score, this is 8 items that kind of measure things like history of stroke, history of focal deficits, and you can score it from 0 to 2. And in Alzheimer's studies, you don't allow a patient to be in an Alzheimer's dementia study if their Hitchinski score is over 4. Okay? But usually folks with vascular dementia, they have Hitchinski scores greater than 7, and this fellow is much greater than 7. And then when you image them, when you neuro-image them with an MRI, what you see are white matter infarctions or lacunae. These are little islands where there's been damage and the neurons are gone. What you see in Alzheimer's dementia is loss of volume, and primarily in the hippocampus, okay? Especially when you compare it to age-matched controls. So now DLB. So 72-year-old man, 6-month history, so this is coming on somewhat acutely. Cognitive impairment, could be Alzheimer's, and visual hallucinations. But, time out, forget dementia, this is psychiatric. He's seeing things. And he goes to the emergency room because he cannot keep from falling. Probably he doesn't go. He's brought in by people who love him. And his bride says, something's wrong. He's really slowed down, thinking, speaking, doing his routine. And when you examine him, he's rigid. So you're thinking, maybe Parkinson's disease. He's got a Parkinsonian-like gait, peggy paw gait. Okay. And he's a wooden Indian. There's no expression in it. And he's not taking any medicine. So he's pretty healthy, okay? But the visual hallucination throws you for a loop. You say, forget about neurology, call in the psychiatrist. This fellow's seeing something. That's going to happen in the emergency room. He fell, he's seeing something. 2 and 2 together. So you call in the psychiatrist. Long story short, he doesn't have a psychiatric illness. He has Lewy body disease. These are inclusion bodies. They're different from senile plaques. They're different from neurofibrillary tangles. Okay. And, they've got core features and secondary features, but these folks have waxing and waning attention and impairment. And they see things. Usually it's stereotyped. And they're bizarre. I see a green frog in my right upper visual quadrant. Okay? And they have Parkinson-like features or symptomatology. They often have a lot of falls. They faint because their autonomic nervous system isn't working quite right. Here's the torturous one. So they see things, so well-meaning physicians give them antipsychotics, having visual hallucinations. And guess what? it makes them so much worse. So now we're in deep water, okay? Their REM sleep is horrifically disturbed. If you put them in a sleep lab and study their sleep, it's just a horrible disorder of REM sleep. And what happens in REM? That's when we dream, right? Lots of things go on. We also think we do a lot of memory consolidation. And depression's pretty common. So let's compare and contrast the DLB patient to the Alzheimer's patient. So we see some Parkinson-like signs, okay? We're not going to see that in Alzheimer's dementia. We see some psychiatric symptoms, but it's confined primarily to visual hallucinations. And they wax and wane. Some days they'll look great, other days they'll look better. The only way they'll wax and wane in Alzheimer's dementia, it's always pretty much the same slow tumble, as if they happen to be delirious, and that can be confusing. Their verbal memory is pretty good, not so in Alzheimer's. This is kind of fancy talk here in terms of type of memory that's worse or better. Executive function, they look a little more like the vascular people. You know, it's poor and it's early on. They have a lot of trouble with things that require attention. You know, the intersecting pentagrams on the mini mental status exam, clock drawing. Autonomic dysregulation. This means their blood pressure and pulse jumps up and down for no good reason. That's part of the reason why they fall. And then the real doozy, if you give them an antipsychotic, it aggravates things or makes them even stiffer. And, you know, sometimes small doses of antipsychotics in the late stage Alzheimer's patients is helpful. So there's a variant here of DLB called Parkinson's disease dementia. So this is just getting a little more fine-tuned, okay? And, you know, this is probably, for if there's neurologists in the audience, help me here. These are just some broad spectrum differences, but, you know, you say, well, isn't Lewy body, since it's got some Parkinson-like features, isn't it lumped under the same thing? No, because of these Lewy body inclusions that you don't see in the dementia of Parkinson's disease. But there's other differences, okay? Tremor is extremely common in Parkinson's disease dementia, less so in Lewy body. Usually more on one side, Lewy body bilaterally. You don't see that syncope, you know, the trouble standing up and falling as much in PDD. They both don't do really great when they get more dopamine. And cognitive impairment, this is really the touchstone. The dementia of Parkinson's disease is usually seen 2 years after the diagnosis of the motor disorder. So it's downstream. With DLB, they're kind of linked together. So the last one, frontotemporal dementia. So here's a very young woman, a literal puppy, 50 years of age. And this is a responsible administrative assistant in a high-functioning, high-flying company. And the last 2 years, her coworkers noticed her behavior is changing. She used to be Johnny on the spot, multitasker, extremely conscientious, and now she is irresponsible and doesn't concentrate, doesn't finish things. She seems to just be ravenously hungry, and she's gaining weight rapidly. And she's become Dr. Weiss-like in telling lies and jokes, okay? She's caught stealing office supplies. This is a conscientious employee. Doesn't bother her. And she picks up things and sometimes puts them in her mouth. Sounds almost like an infant, you know, that orality. Her hygiene is tumbling fast. when you examine her, you just find these very primitive reflexes, the palmar-mental reflex and the grasp reflex. Other than that, it's normal. And look at her mini mental status exam. It's pretty good. 29 out of 30. But her clock drawing is dreadful. It does not compute. What is this? So look at her age, and look at the presenting piece. It's not memory, it's not motor, it's not plumbing, okay? It's this bizarre personality. So what happens to these poor souls? They get vectored to psychiatry first, okay? Because FTD presents with really striking personality and behavior changes right out of the gate. That's the first horse out of the race, okay? So they get diagnosed as late onset, you name it, to psychiatry illness du jour, or a personality disorder, but that doesn't compute, because what do we know about personality disorders? By definition, it's lifelong maladaptive traits, okay? This isn't lifelong. She's a good worker. So let's compare and contrast. FTD hits you when you're young. How cruel. It's rarely in the old, okay? Behavioral problems, they're common, and they are dramatic. They are inappropriate. So I have a patient his lovely bride has actually created little 3x5 cards, kind of like, you know, your business card. And when her husband acts up in public, and the public is appalled, they'll often go into a public place and they'll say, I'm going to kill everybody here, which usually gets everybody primed in our culture. She hands out cards that says, my husband suffers from a type of dementia, please excuse his behavior. Memory impairment, it's not that prominent early on. Language problems, there's a variant of frontotemporal dementia, it's called primary progressive aphasia, where it's just dramatic in terms of their loss of language, like that, like a shot. Motor signs, they're more common than Alzheimer's disease, but nothing like what we saw with Lewy body dementia. Their moods, so there's a funny word there, alexithymia, you know, from the Greek. Alexa, loss of, thymos, emotions. So these folks are unempathic to what they do and to what others do. You know, they are emotionally, or they are emotionless. You know, almost as kind of a heightened autistic feel to it. They are unempathic. Although previously they've been warm and empathic. Okay. They're usually pretty apathetic folks, different from what we see in Alzheimer's dementia. In terms of psychotic features, usually they're very bizarre, you know, as opposed to Alzheimer's dementia in late stage, it's more persecutory or intruder, you know, someone is coming in that I don't know. And then the last one is that orality, okay? You know, they gain weight, they have cravings, they put a lot of things in their mouth, so FTD. So compare and contrast. Now, remember the Jesuits, remember history? So, whoops. I don't have it here. Shame on me. Do we have a minute to plug something in? I don't know if I'll get to it. A little flash drive. I didn't send you those. So I'm going to show you 2 or 3 slides to kind of shock you. So there's a doctor named Gaz Moniz. If we go to the, let's see, yeah, let me zip it up here. So I just want the removable disc. So Gaz Moniz, in 1937, he's a neurologist, neurosurgeon in Europe. He was the first one to do a frontal leucotomy, okay? And actually in 1949, Gaz Moniz was awarded the Nobel Prize in Medicine. She's looking right now. So in the late 40s, this idea of curing people with serious illnesses. Oops, hold on, we'll get it. Oh, you know, we might not. Let's see. Might not be able to get it for you, dang it. In the 1940s, we had these serious illnesses, schizophrenia, bipolar illness. We had no treatments for it. Electroshock had occurred. I don't know if this is still spinning up here or not. So in this country, people began to do frontal lobotomies. And we all know this from the movie and the book, One Flew Over the Cuckoo's Nest. They get a personality disordered guy in a psychiatric hospital and he makes trouble. Yeah, it's that very last one that I'm trying to bring up. We'll just forget it. I'm driving these folks nuts. I wanted to show you a black and white picture of Walter Freeman and James Hall. They're doing a frontal lobotomy in 1947. And all they're wearing is a white coat, and they have a mask on, no gloves. They have the patient on a gurney with 4 nurses holding him down, and they're introducing about a 12-inch blade through the puncta where they would sweep. Okay. And then I would show you a radiograph. No, it's okay. Show you a radiograph of where this blade would be sweeping the frontal lobes. And the idea was we'd now take people that were agitated and we had no treatment other than to essentially imprison them, and we'd make them docile. And quite often, it did make them docile. It also destroyed them in many ways. So the last slide I was going to show you, the picture is, when was the last frontal lobotomy done in the United States of America? Throw out a year.
1971.
Close. Excellent. 1967. How many frontal lobotomies were done in the United States? 50,000 plus. So we just finished talking about a dementia, frontotemporal dementia, in which the frontal lobes are essentially dissolving before our very eyes. And these patients lose judgment, okay, and become inappropriate. And the frontal lobes are inhibitors, are brakes, B-R-A-K-E-S. Yet up until 1967, as a treatment modality, and this is kind of the history, the bizarre and strange history of medicine. They were done on tens of thousands of people in this first world medicine country. So in conclusion, what do we get from this? So we got to take a history, okay? Remember our elderly couple at the beginning. We get a lot from history. When did this start? What other conditions do you suffer from? How long has this been going on? How old are you? When did it begin? How did it kick off? Do you notice any other features, like hallucinations, like trouble with sleep, with dreams, okay? Like inappropriate behavior, orality, weight gain, because these are the 4 most common types of dementia, and they all have a different cause, a different course, and a different treatment in 2015. And here's how we'll sum it up. 1 sentence, okay? Might be kind of a long sentence. So Alzheimer's dementia, memory. Vascular dementia, plumbing. Lewy body dementia, motor. Frontotemporal dementia, personality change. So memory, memory, plumbing, motor, and personality change. It's just kind of a simple way to lump things, but it kind of gives you a little launch platform, okay? A little launch platform. So, we're supposed to finish at 10 after 5, 20 minutes from now. Any questions? I'm teasing you.
Questions, anybody, questions? Question, yes?
Going once,
Going once,
going twice, going 3 times.
Didn't I say he was gonna be good?
You guys are good for putting up with me. Thank you.
Okay, ladies and gentlemen, thank you so much for being with us on the first day. Again, we'll be here all week. Drive safe, and also turn in any forms to the back desk. Anything you want to turn in, just put it in over there, and Barbara Giles will take it from you. And we'll hope to see you tomorrow. Thank you.
Rainy afternoon, swinging hot, motor trips, burning toast.
So it's over here. It just came up.
And all right.
So let me go to the removable dish.
The parthenon.
And moments on the Hudson River line.
I'll be with you in 1 second. I'm dressed. I have to scoot up at the end and I don't go.
Many is the time to be
Maybe
oh, well, it was swell while it lasted. We did have fun and no harm.
there it is. Son of a gun.
Thanks.
Wait, put it on there. Here you go. If you want to see that, here's the picture.
Picture.
Might have been a headache,
Wait, there's
but
more.
you never were there.
I just wanted to say I looked up the Alzheimer
Have a memory
diabetes 3.
of China's funny transplant.
I think there's a correlation
Weekend
between
at
the diabetes. I had never heard of it.
Well, see, so this is worth it right there. You're not going for it, so.
Thank you.
Thanks for
Have
checking
a
in.
memory
I introduced you.
of lunch.
Oh, yeah, I
It
do.
was last year
I
at
Too.
the,
Yeah, thanks.
That pair of gay pajamas that you bought and never wore.
no, this is one where at the Alzheimer's Association, we were over at the,
That couldn't be put in a day wide.
Too bad it all had to go haywire. That's life, I guess. I love